This next presentation is on stroke. Stroke diagnosis is a clinical one. It's diagnosed by the rapid onset of a focal neurological deficit. If it's a slower onset, then it might be a space-occupying lesion. And if someone presents with a syncope, that is not a neurological cause. People with a stroke do not present with syncope. You should be thinking about other causes of syncope, such as cardiac or a seizure. Also, abnormal movements like twitching are not causes of a stroke, are not symptoms of a stroke. When you're doing your clinical assessment, of course, there's the quick, fast test, looking at the face. Is there a palsy, a seventh nerve palsy? Is the arm weak? Ask them to raise both arms up in front of them and see whether there is any pronator drift. Listen to their speech, and if they or their relative is telling you their speech is different or slurred, then do take that into account and very seriously. And T is for testing all three of those elements. And if one or more is abnormal, suspect a stroke. Now that's a kind of assessment that is done in the community by the London Ambulance Service and also by a lay person. I'd expect you, when you're examining a person for a stroke, to be doing a much fuller and thorough neuro exam to really identify what the exact neurology is, to ensure that we actually think that this is a stroke rather than any other pathology that causes focal neurology. So when you're approaching a patient with a query stroke, of course you always assess your ABCDEs at the beginning and test the glucose and manage each of those components if required. You also want to know when the onset of the symptoms and signs are and whether they're still present or not. When you're examining the patient, as I mentioned, you want to do a full neurological exam, which is obviously assessing their Glasgow Coma score, looking at the pupils, checking that they are equal and reactive, and doing a neuro exam on their limbs, so tone, power, reflexes, sensation, coordination. It's also important to do a cardiac exam because if the patient's in atrial fibrillation, that will raise your suspicion of an embolic cause of the stroke, and consider whether there's any seizure activity. A seizure itself is not a cause of stroke. However, people who've had strokes before can have seizures. And someone who is having a seizure, you want to be considering what are the other differentials and causes of a seizure. When they've had a stroke, they may have fallen and hit their head or neck. And so consider as well there could be more than one pathology going on in the patient depending on what's happened when they have had the stroke. And assess whether you actually think they have, based on all your findings, whether you actually do think they've had a stroke or not, or whether there's some other particular cause for it. And if you're not sure, then please talk to a senior doctor. So let's think about the differential diagnosis of a stroke. Of course, the cause of the stroke could be ischemic, so thrombotic or embolic, or it could be hemorrhagic. So there are lots of other conditions that can lead you to believe that the person may have had a stroke, and that is why taking a really adequate history and a neurological exam is key to differentiating between whether you actually think this person's had a stroke or not. So other differential diagnoses could be trauma to the neck, so causing a neurological deficit below the level of the neck. Usually that's located to a particular dermatome or myotome, and it's a radiculopathy, or you'll have evidence of bilateral symptoms if there's, for example, a cervical cord injury. Meningitis or encephalitis can also present with focal neurology, as we've discussed in our neurology lecture, but you often will see other features such as fever, neck stiffness, confusion, there may be a travel history. Intracranial mass, often the history is much more chronic, and you'll have symptoms of raised intracranial pressure, like worse headaches in the morning, or with coughing and straining, and that applies for the tumour as well. Consider a subdural hematoma in perhaps an elderly person who's fallen and hit their head. Often they're on anticoagulants. They might have a several-week history of being slightly more lethargic or confused than normal, and often these have had a minor head injury perhaps, and then they've got a hematoma on the brain that's either slowly getting bigger or is just causing constant pressure on the brain. Other possible differential diagnoses of a stroke are a patient who's had a seizure and then might have persistent neurological signs such as a TOD paresis, where they have weakness down one side of their body and that just resolves. Also, migraines can cause a similar thing. They can cause odd sort of focal neurology too. Metabolic causes such as hyponatremia can also cause the patient to be quite confused and slurring in their speech. Also, high blood sugar or very low blood sugar can also cause an alteration in their sensorium. Equally, after someone's had a cardiac arrest, because they have ischemic brain injury, that may cause some focal neurological deficit, and someone who's ingested any drugs or opiates as well may display symptoms of confusion which could be misinterpreted as a stroke. So how do we categorise the stroke syndrome? We can look at it as anterior or posterior. The anterior stroke is the common one we see where the patient presents with unilateral weakness. They also have a speech impairment and usually the homonymous heminopia, so vision loss down one side. In the posterior circulation stroke, it's more common to see cerebellar signs, so do your D-Danish test. They have vertigo, dysarthria, and also unilateral weakness can be present, as well as a heminopia or occipital blindness. So there are certain criteria to do an emergency CT scan for acute stroke. Someone who has an indication for thrombolysis, and we'll go through that in a bit more detail on the next slide. Somebody who's on anticoagulation treatment such as warfarin, rivaroxaban, clopidogrel. If someone is known to have a bleeding tendency, if they've got a depressed level of consciousness, or if they've got unexplained or changing symptoms at all. Certainly there's evidence of raised intracranial pressure such as papilledema, neck stiffness or fever, or if there's a very severe headache at the onset of it. Those are all indications for us to get an urgent CT in A&E. So ischemic stroke may benefit from early thrombolysis. This is only available in hyperacute stroke units, of which the PRUH-ED is one. If the stroke is likely and there's been an onset within 4 hours, the patient needs to be reviewed by a senior doctor. And if we think that they've had a stroke and it's within the 4 hours, then you have to bleep 2222 and ask for the acute stroke team. They will attend the patient as an emergency, and a CT scan will be arranged urgently to rule out hemorrhage. Once you've ruled out hemorrhage, that means that they can consider doing a thrombolysis. We do not need to discuss that with a radiology consultant. However, for other CT scans, that is required. So other than thrombolysis, stroke patients do their best with a specific stroke care bundle, which they get from a multidisciplinary team in a specialist unit, which is on our HASU. And that really has the core purpose of trying to minimise any functional deficit and avoid complications, and of course reduce the risk of further stroke and optimise recovery and re-enablement. I've just put the bleep number there for the stroke JCF at the bottom, bleep 195, if they are required for any of your patients. So TIAs, transient ischemic attacks. The initial assessment is very similar to a stroke, of course, and the diagnosis of it is essentially a stroke that has full recovery in less than 24 hours. Of course, you're only going to know that if the his symptoms have already resolved in the department. If anyone has any persistent symptoms, then they need to be assumed to be having an acute stroke. In the same way, a stroke, TIA does not cause syncope, does not cause seizures, it does not cause confusion, does not cause loss of consciousness or a funny turn. If a patient presents with any of those things, it's very unlikely, well, it will not be a stroke or a TIA. You must think about other causes for it. So, as I mentioned before, the decision between whether it's a TIA or a stroke, a TIA, you have complete recovery within 24 hours, and 95% of them recover within an hour. But if you see a patient who's got persistent symptoms in the ED, you must assume that it's an acute stroke because you don't know if they're going to resolve. And nearly all of the remaining patients who don't recover within an hour do have abnormalities on their MRI, even if they actually clinically do recover in more than an hour, i.e. actually they've had a stroke. So we used to risk stratify the patients using the ABCD2 score. We don't do this anymore because the risk for recurrent stroke is actually up to 10% in that week following their TIA. So it's just not safe for that patient to have to wait to be seeing a stroke specialist. They need to get on and have the right investigations and management now to prevent that major stroke from happening. So the management of a TIA is to reduce that risk of a stroke by modifying any risk factors that can be altered as soon as possible, such as hypertension. And when we assess that patient in the ED, there's a specific pro forma to follow to decide where they need to be referred to. So if someone presents with a TIA and the symptoms have fully resolved and the TIA was more than 7 days ago, you follow the yes pathway, and that's when the patient can probably be allowed home. You can do an online TIA referral, prescribe 300 milligrams of aspirin, and then once a day, and you email a referral form to the address on this slide with a notice and an ECG. You need to tell the patient they'll be telephoned for an appointment, usually within 3 working days, and they should not drive until they're seen at the clinic. Certainly there's a witness to the event. They should come with them to the appointment so that they can explain to the clinician exactly what's happened, and they must call 999 if they get any further events. If the symptoms are fully resolved but it happened less than 7 days ago, then they must be referred to the stroke SHO for assessment today, and as I said before, that's oblique 195 or the stroke consultant via switchboard. And you can get an immediate CT scan for these people if they're on anticoagulation. So drugs which make a difference and treatments for TIA, they can start antiplatelet drugs such as aspirin, anticoagulation of patients who are in AF, and also carotid endarterectomy. These are not for us to start in ED unless they're that TIA patient who's had the TIA more than 7 days ago and is going to be seen as an outpatient, in which case you give them the 300 milligrams of aspirin. If there are any questions, then please come and speak to us directly when you start in your job. But the main thing is if you've got any concerns about the management of a patient or queries, then please do speak to a registrar or a consultant.